So please do the non-invasive one, choose non-invasive one over the invasive one. But if they specifically ask for the invasive one, then definitely you have to choose the invasive one. So you are going to start with the 60 years of the age. And if there's a family history, you are going to start with the 50 years of the age. Recommendation not screening after more than 75 year of the colorectal carcinoma. Then recommended not using colonoscopy as a screening test. Sigmoidoscopy can be used and FOBT, but FOBT is preferred over flexible sigmoidoscopy. Why? Because this is non-invasive one. Now, age, man and woman, if they're symptomatic, you're going to do the diagnostic workup right away. If they're asymptomatic, you are going to look into the family history, regardless of the age. If this is NHPCC, HNPCC is hereditary non-polyposis colorectal carcinoma, you are going to do or FAP, familial adenomatous polyposis. If there is a family history of it, what are you going to do is basically do genetic counseling and special screening. HNPCC in hereditary non-polyposis colorectal carcinoma, colonoscopy every 1 to 2 years. Begin at the age of 20 and or 10 years younger than the earliest case. So you are going to start it right away whenever you are going to like the person who is being diagnosed. If your the patient is presented to you, or the person who is going to, like, you are going to do the screening, if that is 10 years younger than or 20 years younger than that, so usually they present in those certain type of ages. So you're going to start with the colonoscopy. So especially in these cases we do colonoscopy. You can remember it, it is H and PCC. So with all those things which has seen then, like H and PCC, AAPC, like attenuated adenomatous polyposis, in those ones we do colonoscopy. But in FAB we do sigmoidoscopy annually, begin at the age of 10 to 12 years, and this AAPC annually begin at the age of 16 to 18 years. So just remember the age factor, it's important. If there is a first degree relative with the cancer or adenomatous polyposis at the age of less than 60, or two or more first degree relatives with the polyps or the colon cancer at any age, then definitely you are going to do the colonoscopy every 5 years. So if this is the first degree relative, but the age factor was more than 60, that's why we are going for every 5 year. Because after 60, we are still going to start with the colonoscopy or because in the more than 60 we're going to start with sigmoidoscopy, but here it was first degree relative involved, so we did colonoscopy. Begin at the age of 40 or 10 years younger than the earliest case possible. The polyps of the cancer is present in the family, as we already discussed. If this is already present in the family and the person presented to you is 10 years younger, or at the age of 40, you can start it because he was 50, so 10 years younger, at 40 you can start it. Or first degree relative, but the age factor of that person who presented with the cancer is more than 60, or the second degree relative is involved, so you can do the average screening. You are going to do start with the 60 because it's presented with after 60, right? So after 60 you were still going to start with the sigmoidoscopy, so you are going to start with the sigmoidoscopy as it is. Begin, because it's not going to save or give any benefit to that person, so that's why you are going to start with the average screening. Or begin at the age of 40 or as early as possible, because if that person is getting anxious, you can start it right away. If the second degree relative, average screening or begin at the age of 50. Polyps found at colonoscopy, 1 to 2 tubular adenomas less than 1 centimeter, do colonoscopy in 5 years. More than 2 adenomas, do in 3 years, because there is more chances of getting the cancer. Incomplete examination, polyps or advanced adenomas, malignant or large sessile adenomas, colonoscopy after a short interval based on the clinical judgment. So on the basis of the judgment, you are going to decide if the person needs more frequent examination or sigmoidoscopy or colonoscopy, then we're going to do that. Cervical cancer, usually it says the age after 21. Before 21, we start it. It says that 30 to 69 is recommended one or strong recommended one, and we go for pap smear or liquid based cytology. But what happened is in Ontario, the guidelines is bit different, and like in Quebec it's different. That's why we go with the 31. But if they ask specifically if the 21-year-old female or 25 is sexually active, then go for screening right away. If they're sexually active, go for screening right away, regardless of the age. But it's usually started after 21 years. Okay. So if this is not sexually active, as I said, who or have ever been sexually active, so you're going to start with a 21 year. Usually it started after 25 year we started. because we are not sure we can, do the screening and find out the cancer. But if it's sexually active, you can start after 21 year. But the recommended guideline, if they haven't given you anything and ask you the basic one, you are going to start with a 30 to 69. What are you going to do? Pap smear. How often? For every 3 years. And three consecutive answers to came out to be negative, you stop doing the screening. A woman may discontinue screening at the age of 70 if she has an adequate or negative cytology screening in the previous 10 years, 3 or more negative cytology tests, but in the consecutive ones. Previous 10 years, 3 tests came out negative. Otherwise, whatever the test was done, because it's been done in every 3 years. So in 10 years, you are going to do it 3 times, only 3 times, right? So it should be negative in each time, then you are going to stop it. If it came out positive even in one time, we are going to move on to colposcopy just to make sure. Now to the normal routine screening in every 3 years. Inadequate sampling, repeat in 3 months. Adequate sample, routine screening in 3 years. Now ask us, is abnormal squamous cells of the unknown significance. If the age factor less than 30 or more than 30. If this is less than 30, you are going to do cytology in 6 months. Negative, you are going to repeat it again. Negative, then routine screening. If this came out positive at any time, you go to colposcopy. Now, the scenario I told you, they can ask you if there's a setting and they're living in a rural area and they're unable to go for colposcopy, you can repeat cytology in 6 months. Okay, to confirm the diagnosis. In the 30, you go for HPV DNA testing. Even in that condition, if there is HPV DNA testing not available, you can go for cytology. I'm telling you in those conditions when the HPV DNA testing or colposcopy is not available. If it's available, then go for those ones. If not available, then you can still do cytology. HPV DNA testing, negative, repeat cytology in 12 months. Positive, then go for colposcopy. ASCC, you're going to go for colposcopy. ASCUS, you're going to go for colposcopy. LSIL, colposcopy. Or if the patient does not want to go for colposcopy, usually there is the condition, then you go for cytology in 6 months, negative, repeat again, then routine screening. If came out positive, go for colposcopy. In those conditions, if they still don't want to go for colposcopy, you can always start with the counseling. And if they still don't want, it's up to them. You can go for cytology. Colposcopy. HSIL, we are going to go for colposcopy. Squamous cell carcinoma, go for colposcopy. You are not going to leave that person if that person does not want to go for colposcopy. You are always going to switch to liquid-based cytology or pap smear. And then prostate cancer, usually we don't do or not recommended. So we don't do colposcopy. Now, let's move on to the next one. We are going to start, like we are going to do some more topics from family medicine, but in the next class. Since in this class, we are going to go with the emergency one. We have to do some questions in the end of the class. So let's just make it quick. So in the ethics, let's go with the ethics. So in the ethics, we were going to do truth telling and made. In the ethics, everything is important, but since short of time, we cannot do everything because like if you go by ethics, everything is being challenged, and how you are going to assess that person is very, very important. And there is one tip and trick for the ethics question, how to get the right answer. If in the option, there is an option of discussing, if there is an option of having a conversation, if there is an option of having a conversation with a patient, with a supervisor, always choose that one, because that is the right answer. Before making any decision, if there is an option of choosing a discussion with your supervisor, with the patient, with the SDM, or with anyone, the answer is the discussion, because you have the chance to discuss it again and do the counseling. So in those cases where there is a chance to do the discussion, you can go for the discussion. Now coming to the truth telling, helps to promote and maintain a trusting patient physician relationship. Patients have a right to hold the important treatment. Now the question can be asked, if the person has been diagnosed with certain sort of condition, and their family member is asking to not discuss it with the patient, in those conditions, what are you going to do? Definitely you are going to discuss, but in the scenario you are not going to write down, I'm going to discuss it regardless of anything. No, you are going to discuss this condition with the family member and tell this is their right to know about the condition, and maybe we can help her in better ways and give her motivation to continue with the treatment. So always start with the discussion. And then if they're still not willing, now we go to if and then rule. If they're still not willing, then definitely we're going to discuss this with the patient. If they're still willing, then we're going to appreciate and discuss it together with the patient. Now, if and then rule will be used. Patients have the right to hold told the important information that physicians have regarding their care. Enables patient to make informed or autonomous decision. So it depends on the patient. If they still don't want to go for the treatment, you are not going to make sure that he is going to get it. But the counseling should be there every time. If the person is still denying, every time you visit that person, you are going to do the counseling every single time about the healthcare and their lives. Legal basis is required for the valid patient consent. Goal is to disclose the information that a reasonable person in the patient's position would need in order to make an informed decision. But even if they make the informed decision, like autonomy is there, you are going to still check the capacity, because you as a family physician still think maybe this person, if he was in their right senses, will not make this decision, right? So that's why you are going to check their capacity. Withholding information can be a breach of fiduciary duty and the duty of care. Obtaining consent based on the misleading information or the insufficient information can be seen on the negligent or coercive. Then CPSO policy is basically physicians should provide patients with whatever information that will, in easy words, from the patient perspective and have a bearing on the medical decision making, and communicate that information in a way that is comprehensible to the patient so they can easily understand, not in a complicated information. Now, evidence about the truth telling. It is the patient's right to have the option of knowing about any clinical decision diagnosis that most patients may be provided with information regarding their health. Although some patients may want to protect family members from the bad news, they themselves would want to be informed with the same situation. Truth telling improves trust, adherence, and the health outcome. So you should start with the basic rules of telling them with the empathy. Then informed patients are more satisfied. It's like a breaking the bad news. So informed patients are more satisfied with their care and more often receive news, because the people who don't know what they are going get or getting treatment for, they are very disturbed and feel anxious what they are being getting and what kind of treatment they are getting. So that's why it's very giving them satisfactory about their health better than expected. Negative outcomes or consequences of the truth telling can cause decreased emotional well-being, anxiety, worry, social stigmatization, and the loss of insociability. So they can ask you in the CDM question and in the MCQs, what are the negative consequences of the truth telling can include. So these ones are the negative consequences. So remember these ones. Coming to the medical error may be defined as the preventable adverse events caused by the patient's medical care, not the patient's underlying illness. Some errors may be identified before they harm the patients. So all the errors are truly adverse. So you need to see, if you tell this kind of thing to that patient, what could be the consequences. But still, you need to tell that person about all the medical errors that has been happened during the case, even if it's near harm, or even it has already caused the harm. So many jurisdiction and provincial associations affect and require physician to disclose the medical error. That is, even the harms or threatened to the harm patients may be disclosed to the patient. So whatever is happening, you need to tell the patient. Patient's the decision maker and report to the appropriate health authorities. It's up to them. You can always apologize and always ask them. You can try to correct it in the best way. So empathy should be there. The empathy is the key to everything. Physician may disclose to the patients the occurrence of the error or adverse events or the errors caused by the medical managements, but you should not be disclosing it in the in the covered words, you should be very open about what you have done, and you should tell the patient in a very clear sentence about the should not suggest, but should not suggest that result from the negligence, because negligence, and you cannot put the blame into one person. You as a whole team are responsible. That's what they like to ask. In the medical error, what happen is if they ask, one team member made the mistake and you are the in charge of it, it does not mean that that one person should be pushed aside and you are going to put the blame, whole blame onto that. You as are in charge is the one to be liable and going to apologize and correct the thing. They would like to see if you as an in charge, if you are a part of team, would like to put the blame to that member. No, it's not like that. Even if the nurse is the one who is liable, you are not going to put the blame to that person. You as a whole team will take the blame. Negligence is the legal determination. Error is not equal to negligence. So error can happen in many of the cases. So it is not negligence is all the time. Negligence is something else and error is something else. Disclosure allow the injured patient to seek appropriate coercive treatment promptly, because if they know what happened, they can go for the treatment right away. If possible, physician should avoid simple attribution to the cause and sole responsible of the others or oneself. Patient should offer apologies and the empathic expression of the regret, as they may help to maintain or rebuild trust and not admission of the guilt or liability. So you can always apologize. Apology acts across the Canada, protect the apologies both as an expression of the regret and admission of the responsibility from being an effect, it evidence of the liability and negligence. So same as I said, breaking the bad news in the truth telling is important. Setting perceptions, invitation, knowledge, and empathy and strategy. So you are going to follow this one. They can ask you what are the spikes. Okay. Then adverse event and an unintended injury or complicated from the health care management resulting in the disability, death, or the prolonged hospital stay. Now talking about the maid, just wanted to let you know that medical assisted death is not legal in Canada anymore. So here it is. Euthanasia and medical assistant in dying. Euthanasia, knowing and intentionally performing an act with or without consent that is exclusively intended to end the person's life where that person has an incurable illness. Medical assistance in dying is basically administration. It's just another name of euthanasia. It's kind of same. You are administration a self-administration drug to that person, and they try themselves to kill themselves, right? So a substance at the request of a person that causes their death. So common ethical arguments is basically different. So knowing the criminally prohibited medical assistant may influence some individuals to end their own life. So what happens is basically people sometimes are depressed and ask them to do the maid. Usually before it was not legal. But these days, sometimes in some says this is legal and some says it's not legal, but usually in the Toronto notes it says usually we don't go and help that because it's against your own beliefs. So you can always refer that person to psychiatrist or some other doctor, and if they are willing to do that, then they can proceed with that. Patient has the right to make the autonomous choice about the time of their own death. Believe that there is no legal or ethical difference between the acts of euthanasia and assisted suicide or foregoing life-sustaining treatment. Palliative care. So if somebody's going for maid or something like that, you can always discuss the palliative care and give them alternative options. And these things should be discussed. Palliative care is an approach designed to improve the symptoms and quality of the life for the duration of the person's life. But unlike MAID, it does not aim directly at or intend at the end of the person's life. Many palliative care physicians are incorporating MAID into their practice, though some may conscientiously object. So it depends. There is controversy. Like some is okay and some is not okay. But in Toronto notes, it says it's okay to do the MAID. So if in the scenario they ask if you are going to do the MAID, then definitely the answer, according to Toronto notes and according to Canadian recent guidelines, they allow to go for the MAID. But it keeps on changing. So just before going for the exam, if you have time, check it, because they keep on changing every day and day and day. So, but let's suppose if you didn't able to check it in the exam, you have to make the choice. So in the according to Toronto notes, you can choose it and it will be right, I guess. Then believe that these acts benefit terminally ill patient by relieving suffering. Believe that the patient's autonomy has limits and cannot or should not be allowed to make an autonomous request to end one life. Always check the capacity before making the decision. That should be consequences of the morally justified withdrawal of the life sustaining treatments only in the case where there is a fatal underlying condition. Like, you have to make sure that this person is eventually going to die. It is a condition, not the withdrawal of the treatment, that caused the death. Obviously, the condition is going to make the death. It's just we are stop giving the medication for that specific treatment. So the condition is killing the person, not the treatment. An argument presented in the Carter's case suggested a permitting maid will detract the support for palliative care. So what happens is, if you are giving maid, people who wants to get the palliative care still not able to get the palliative care. So that's why it's just a controversy. The number of requests for the maid could decrease if you give the proper palliative care. Here is this one, the 2015 one. The criminal prohibition on the insistent in the substance is non-constitutional to the extent they prohibit physician-assisted death for the competent adults, people who clearly consent to the termination of the life and has grievous and the irremediable medical condition and causes the enduring suffering that is intolerable to the individuals and the circumstances of his or her condition. Later on in 2016, they legalized the maid, but later on they said you need to check the consent. But at the same time, you need to see if the condition is going to kill that person or not. Based on that, you are going to make the diagnosis of making that maid. And there is a whole committee that sit down and talk to that person. So there is certain things that you have to pass through. Now the criteria for the made patient is eligible for the publicly funded health services in the Canada, so they can get the what it says palliative care at least 18 years, has the capacity for the clear and freely given consent, so they can grievous and irremediable medical conditions in an advanced state of irreversible decline in the capacity suffering. So if you find out that later on maybe that person lose their capacity, so if they are willing to make their decision right now, so you are going to follow that decision. Suffering intolerable to the patients not relieved under the condition they consider acceptable, recent acceptable. So made process is basically, eligibility criteria should be satisfied, patient sign and say dates should be there, written request. It's so they can ask you, a person who wants to go for the maid, they have signed the document, but it's expired. The date and the signs is expired and the person does not have a capacity. So are you going to go for their maid? Definitely in this condition, you are going to call the ethics committee. But if that suppose there is no option to that, you are not going to go for the maid. Maybe right now the patient's willingness to getting the maid would be changed. So you are not sure. That's why you are not going to do the maid. If it's expired, you are not going to do. Then two independent witness sign the written request, and they can ask you, then one of the witness ask you to change it later on or blah blah blah. So in those conditions, definitely you can change by discussing it with the patient first. Otherwise, on the basis of only the witness, you cannot change it. Witness must be 18 years or more, understand the nature of the maid, and may not benefit from the death. That is very, very important. That person should not be financially linked to that person. Be an owner or operator of the healthcare facility. So he should not be a doctor or he should not be in the health facility. Be directly involved in the provision of the health or provincial care of the patient. So he should not be at the caretaker or mother or father or anybody who is like that doing the taking care of the patient. So it's important to know who is going to be the witness in maid. So they can ask you who could be the witness of the maid. HCP, healthcare physician, must inform the patient that they can withdraw their consent at any time. It doesn't mean that they have signed it, so it's going to be happening. Healthcare physician must inform the patient that can withdraw their sign. Two independent assessors, like physician or the neurophysician, must provide the written confirmation that eligibility criteria are met. 10 clear days must elapse. So there should be 10 clear days after the signing where they can still reconsider the date on the maid is provided, unless the both healthcare providers agree that a shorter period is appropriate because the patient is eventually going to die. So if the shorter period is needed, so they can do in the shorter period. As per the new maid legislation in 2021, a patient may request maid even if the death is not reasonably foreseeable, like in the patient who is depressed, a patient who is going through diabetes and have neuropathic pain. If they want to request, definitely they can. For the patient whose death is not reasonably foreseeable, so in those conditions, definitely if they want to request, they can. Their eligibility requestation is up to 90 days. So usually it's 10 days, but in these conditions, this is 90 days. Unless assessment are completed sooner and the patient is at the immediate risk of losing the capacity. Like, in the cases like depression or delirium or those conditions. Throughout 10 to 90 days period and immediately before providing MAID, the healthcare physician must give the individual an opportunity to withdraw the request. Keep on asking and counseling. Ensure the patients expresses consent or the receive MAID. Contravention of this process is an offense punishable by up to 5 years in prison. So if you go against it, you are going to be punished. As of the change of the legislation 2021, a patient may waive the requirement of giving final consent about the MAID in the administered only if the patient death is reasonably foreseeable and while the patients had decision making capacity. Only then he can actually change the day. Assess and approved for the MAID and advise that they are risk of losing capacity to provide the final consent, and the patient makes a written arrangement with the HCP where the consent is advanced to receive MAID as on chosen life. Like they have already written, even if I lose my consent and I want to go for MAID, then I will go for MAID. No longer has the capacity on the date. So made ethically appropriate actions, respect the capable decision to forego available treatment options or the palliative care, as I said, counseling, then provide the appropriate palliative cares with the patient consent, right? And try to assess the reason for the MAID. What could be the cause, like depression, pain, loneliness, anxiety, and try to give the alternatives, right? So I hope this gives you an idea. If there is a question from MAID, how are you going to do that one? Otherwise, ethics is very important. I would suggest you to go through ethics. And by tomorrow class, if you have any question through ethics, you can always ask me. So we are going to go with the emergency medicine. So starting with the rapid primary survey. Starting with the primary survey, let's suppose if there is a question where they were asking you, a person who just has a trauma to his head, what is the next thing you would like to do? So the first thing first is C spine control, then airway maintenance. Because he has a trauma to head, maybe his neck is also had a fracture, right? So even if you do the airway maintenance, if the C spine is not in the normal position, the airway will not it will not be corrected. That's why in those conditions where there is a head injury, there is a spine injury, or where you have to transfer the patient from the road to an ambulance or to the hospital, first thing is always C spine control. Then go for airway maintenance. It's important. Airway maintenance with the C spine control, then breathing and ventilation, then circulation, disability, exposure, and environment. And in those conditions where the circulation is affected, in those conditions, circulation comes first. Okay. Exposure and environment continually reassessed during the secondary survey. Changes in the hemodynamic or neurological status necessitate a return to the primary survey, beginning with the airway assessment, starting with the airway assessment. As they said, you can start with ABCs, and if needed, you can switch to CABs. ABCs is the hallmark of it, airway, breathing, circulation. And if there is a heart arrest or cardiac arrest, then you are going to do the chest compression, airway, and breathing. So now you are going to apply it on the basis of the what is required. CAB can also be applied in the massive trauma condition, in the massive of the blood loss to treat the hypovolemic shock. Now, primary approach to the critically ill patient, you are going to start with the primary, then resuscitation, then detailed secondary survey, and then definitive care. Signs of the airway obstruction is agitation, confusion, universal choking sign, respiratory distress, failure to speak, dysphonia, stridor, and then cyanosis. Then, obviously, starting with the airway, obviously securing with the C spine, putting the collar around it, but starting with the airway, airway is the first priority to secure airway. Assume a cervical injury in the every trauma and immobilize with the collar. So starting with the immobilization. Even before putting the C-spine collar, the immobilization is something that is more important. Assess the ability to breathe and speak, can change the rapidly throughout, reassesses frequently, and assesses for the facial fractures, edema, and the burn. Now, moving on to the next one, the airway management, anatomical optimization. Basic airway management is basically protect the C-spine, chin lift, or jaw thrust only if its C-spine injury is not susceptible. Okay. Then sweep and suction of the clear mouth for the foreign body. Then temporizing measures nasopharyngeal airway, oropharyngeal airway, rescue airway devices, transtracheal jet ventilation through the cricothyroid membrane. That's what you are going to do. Then affinitive airway management, ETT, and intubation with an inline stabilization of the C-spine, orotracheal RSI, or residual uh, airway breathing circulation performed preferred, and then nasotracheal may be better tolerated in the conscious patient. So only the nasotracheal will be put in on the patient who is conscious. Otherwise, orotracheal tube in the patient who is not conscious. Now they can ask you, if the person is conscious, what are you going to use for the definitive airway management? If it's not, then you are going to do the orotracheal one. Please remember this one. These small words make a big difference when you are choosing between the MCQs. Surgical airway, and then cricothyroidotomy. Contraindication of the intubation. When are you not going to do the intubation? Where there is a pathology, like there is already obstruction, or there is a COVID-2, yeah, like COVID-19, then intubation, CPR, or other arousal generating procedures in the absence of the full PPE. Then medication that can delivered via ETT. Sometimes they ask in the MCQs these kind of things. Naloxone, atropine, Ventolin, epinephrine, and lidocaine. Indications of the intubation. Patent's airway protect against the aspiration, especially in the GCF less than 8, positive pressure ventilation, and the pulmonary toilet. Then rescue the technique in the intubation like bogey and then glycoscope. So if you can remember these ones. Breathing is basically you are going to look for the look, listen, and feel. If the person is mental status is fine, there is no loss of consciousness, no anxiety, no chest movement disturbed, or respiratory rate is normal, nasal flaring is normal, there is nothing else, right? In the look wise, he's totally fine. It means that this person is okay. Then coming to the listen, you are going to auscultate for any obstruction, any pneumothorax, any absent of the breath sound. So these things, symmetry of the airway. Then feel tracheal shift or any tracheal tug is present or not. Then crepitus is present or not, because it can show the emphysema, flial segment. So you are going to assess the breathing on the basis of look, listen, and feel. They can ask you in the CRM question how you're going to do the breathing assessment. So rate, oximetry, ABG, and AA gradient are the quantitative measures of the respiratory function. O2 delivers, the more is going to be delivered with the CPAP and IPAP, and then high flow cannula. Then the least one is nasal prongs. Management of the breathing is basically started with the nasal prongs. Definitely the only nasal prongs is available right away. So you're going to start with that one. And then if the person needs CPAP, BiPAP, you can switch with that one. So starting the nasal prongs, then go with the simple face mask, then non-breathable mask, and then high flow nasal cannula. Circulation, you're going to start with the checking if the patient is in the shock or not. Then what type of shocks? Hypovolemic, cardiogenic, distributive, and obstructive. More than these are the causes. Hemorrhagic shock, where there is a lot of bleeding. Then severe burns. Then output fistula, dehydration. Cardiogenic shock includes myocardial ischemia, dysrhythmia, CHF, cardiomyopathies, cardiac valve problems. So in distributive, there is septic and anaphylatic. Obstructive, there is cardiac tamponade tension and pulmonary embolism. So these are the type of the shocks. Degree of the shocks depends. Less than 750, just need to remember the blood pressure once it's increasing and then keep on decreasing. The blood volume is basically increased by the fourth stage. Pulse, it's going to tachycardia. First is bradycardia, then it's tachycardia. So remember, if there is a tachycardia and decreased blood pressure, it means the shock is very severe. Even the respiratory, the patient is in respiratory distress, capillary refill will be decreased, output will be decreased, and then fluid replacement will be given. In the starting, you give crystolloid, and later on should be given in the blood. Even now, crystolloid is not effective anymore. Causes of the shock, septic and hemorrhagic, so all of those things. Management of the shock, clear airway, breathing, circulation, first thing first, then always apply for the direct pressure on the external wounds to decrease the bleeding. while elevating the extremities. Do not remove the implants if they are there, because they can cause the tamponade bleeding. It can stop the bleeding for time being. And then start two IV bore line, IV lines. So if they ask what are you going to do next in the CDM question, start with two IV bore IV lines, then give IV normal line, then moving on to these ones. If they ask for three options, what are you going to do? Two secure two IV lines, two large bore IV lines. Second, arrange, CBC, like send for the cross match, then arrange the blood. These are the most important one. Then obviously transfusing the IV fluids. First is First is putting on the two IV bore IV lines, starting with IV fluids, and third is cross match blood, arranging for the cross match blood. So these are the three things you are going to write down. Like first thing, if they ask for the most important one, then arranging the blood is important one. But if they ask for what is the next step management, that's giving the normal IV saline. Start two large bores in the IV in the brachial and the sphenic. Run 1 to 2 liter of IV normal saline, but it should be very important because it can cause a lot of edema. So you should make sure that what you are given is given properly, warmed if possible. If continue bleeding or no response to the crystalloid, go for the cross match blood. So even if the crystalloid is not very effective these days, that's why we go for the cross match blood right away. Then O negative is given and O positive should be given to those ones who has no cross match blood. FFP, platelets, and tranexamic acid is early bleeding. If available, active massive transfusion protocols. Common sites of internal bleeding is abdomen, chest, pelvic, and large bones. Coming to disability, assess the loss of consciousness using GCS. Pupils assess the equality, size, symmetry, and reactivity of light. So in the question, they can ask you in the pupils, what would you check? Or in the eyes, what would you check? So we will check with the equality, size, symmetry, and reactivity to the light. These are the stupid and important questions that is being asked in MCQs as well as in the CDM questions. So please give them a good read and make sure you remember them. Unequal or sluggish eye light, it means there is CNS lesion, non-reactive pupils, and decreased loss of consciousness. Coming to the Glasgow Coma Scale, they can give you a scenario where you have to calculate the Glasgow Coma Scale. So eye opening is basically of the 4 points, best verbal response of the 5 points, and the best motor response are of the 6 points. So the eye open is spontaneous, 4 voice responses, so you can remember these ones one by one. So total of 15 points. 13 to 15 is mild, 9 to 12 is moderate, and less than 8 is basically severe, and the patient needs intubation. Fluid resuscitation, give fluid until the heart rate decreases, urine output increases, and the patient stabilizes. You're going to keep on giving the fluid until these things are achieved. Heart rate keep on, because tachycardia shows that this is patient is in shock. Urine output decreases, shows this is patient is in shock, and the patient is stabilized. It means the breathing pattern is normal, heart rate is normal, blood pressure is normal. This patient is stabilized. So maintain 4:2 into 1. So for 0 to 10 kg, give 4 cc per kg per hour. For 10 to 20 kg, give 2 cc per